Good morning, everyone. Hope all of you are fine after the pandemic. I would, at the outset, like to thank the organizers of Quadran for inviting me as a faculty in this virtual conference of e-conference, and also the authorities of Caher, Belgaum. The topic which I'm going to talk on is Babat's assessment in stroke patients. Now, all of us are acquainted with the Babat's approach. It's nothing new. The only thing is how we use it and how we interpret the conceptual topics and get out a better treatment. There are so many methods of treating a stroke patient, but Babat seems to be very popular, has caught up with the masses, and it also yields good results. Now, before I get off into the state assessment part, I will briefly run through the rationale of the Babat's concept. As we all know, it's a holistic approach which deals with the quality of pattern of coordination, not only with the problem of individual muscle function. So in a patient like stroke patients, it's difficult to do an individual muscle testing and find out the grade or the power of a particular muscle, but we have to see the problem in its totality, because it involves the whole person, not only the sensory motor problems, but also problems of perceptual, cognitive impairment, emotional, social, functional problems, daily life, etc. And this was said by none other than Babat herself. The brain lesion, as we all know, results in appearance of stereotyped, coordinated, abnormally coordinated movement patterns, which affects a large number of muscle groups, either in the flexion synergy or in the extension synergies. And these lesions interferes with the development of normal postural control. Postural control is something that keeps us upright in relation to gravity. Instead of postural tone, what we get is abnormal tone, which could be hyper, hypo, or it could be a fluctuating sort of tone, sometimes hypo, sometimes hyper. And instead of normal reciprocal interactions, we find increased co-contraction or sudden inhibition of antagonists, resulting in lack of ability to make a graduated movement. As we all know, Babat usually uses the term selective movements. Selective movements is nothing but moving out of a synergistic pattern. Instead of the normal automatic movement patterns of writing reactions or equilibrium reactions or postural reactions, refined static stereotype postural pattern. That's another big drawback. Now, while working with the hemiplegics long back and sometime in 1942, Babat, what she found was, if you can prevent the hemiplegic from moving into an abnormal pattern, which is occurring due to his spasticity, a more normal functional activity is possible by handling. Now, handling, facilitation, as we all know, are key components of the Babat's concept. While working with the hemiplegic, she became aware of three facts. One, it is impossible to superimpose a normal movement pattern on an abnormal one. The abnormal ones needs to be suppressed or inhibited. Now, this we all should agree, because a patient who has come to us with an abnormal movement pattern, you try to teach him a new pattern, the patient finds it difficult to learn it because you have not released the abnormal pattern. Second, the importance of sensory motor experience, because it is a movement pattern that we learn, a sensation of movement we learn, not an individual movement. And third, by moving the proximal part of the body, which is possible to influence and change the movement of the distal part. Now, coming to the assessment, that was briefly to tell you how Babat had actually conceptualized this part in treating the stroke patients. The assessment. Now, normally what we do with hemiplegic, the normal procedure, like we treat musculoskeletal conditions, you find out his range of motion, you look for the tone and grade it in whatever scale you want. But those are not enough. As we all know, the DTR, spasticity, these are all signs of upper motor neuron lesions. And once you know a stroke patient, we know it's an upper motor neuron lesion. So what we can do is identify the abilities and functional capabilities of a patient, and these will include movement of both arm and leg on the affected side, the postural passions of the trunk, and functional independence in life skills. Now again, I would like to remind all of us that when we are talking of stroke, we are talking of paralysis of one half of the body, which includes the trunk and the pelvis. Invariably, what I have seen, that people treating stroke patients, sometimes they ignore the trunk and the pelvis, and which gives a lot of problems later on in the gait training of patients. What we have to look for is how is the patient performing these functions. That is important. Secondly, you identify functional limitations. That means those functions which a patient is unable to do, but they are necessary for improved independence and quality of life. That means these are required daily for his function, but he is unable to perform. Identify and jot down those functions so that you can get some remedy for it. Then you determine what problems interfere with movement control and functional performance. Now, what could be these factors? When we're talking of stroke, it could be abnormal tone, which could be hyper or hypo, or a fluctuating, or dystonia as we call it. Abnormal coordination, that the movements are there, but they are not in a normal fashion. Loss of postural control, patient is not able to keep himself upright, either in sitting or in standing. Loss of selective movement, that is, he is not able to move out of the synergy. Like you ask him to lift his arm, he raises it in one full pattern. And loss of sensation, which does not always occur in stroke, but in some stroke patients, we see loss of sensation as well. Now, abnormal tone. Abnormal tone includes hyper and hypotonia. Hypertonia is a major impairment following stroke. We all know the majority of the stroke patients coming to us are having spasticity or hypertonic. And those who are hypotonicity, you say hypotonicity if a patient, stroke patient, does not get tone, say for a prolonged period of 3 months or 4 months, then naturally we come to a conclusion that his prognosis could be poor, because for normal function we require tone. What we do not require is abnormal tone. Factors that contribute to impairment of muscle tone include spasticity, changes in muscle properties like hypoextensibility. That means the muscle is not able to be stretched fully, contractures develop, and you can also have muscle atrophy. Hypoextensibility causes difficulty to move actively through the full ROM because the muscle is not stretching fully to its length, so obviously the range of motion will be reduced. Contracture is the end result of a hypoextensibility. If you keep the elbow or the muscle is short in position for prolonged periods of time, then you can develop contractures. Atrophy is nothing but the decrease in size of the muscle mass. Loss of postural control. Postural control consists of postural orientation, which anticipates the appropriate relationship between the body segment in a task-specific context. So a patient who is unable to balance himself in standing or sitting, and he would like to reach out to an object or something like that, he will have difficulty in doing it. Postural stability is the ability to maintain the center of mass within the limits of the base of support. Reactive postural adjustments or equilibrium reactions are responses to perturbations from the environment or self-initiated movements or a moving support surface. Like you make a hemiplegic stand and push him to one side or to the affected side, he probably tends to fall off. Or you have the other type of stroke patients called the pushers. They tend to push from their normal side and again they tend to fall off. So these are problems one needs to look into while evaluating. Establish functional goals and treatment goals. Identify the functions that the patient will be able to learn within an established time frame. That is, you have like short-term goals, we always have a limited time frame. Indicate whether performance will involve compensation or use of the involved side with normal coordination. So either the patient, you can teach him how to compensate for when he is unable to use the involved side, or you train him properly using the involved side with some amount of coordinated functions. Identify the impairment that you will need to address to meet the functional goals. Now, this is based on patient response to handling. Determine where to begin. What technique of inhibition and facilitation will be used. Now, handling, like I told you, is an important component of the Bobot's concept. Use inhibition techniques, decrease abnormal muscle tone, which you find is interfering with passive and active movements. Try to restore the normal alignment of trunk and the extremities by lengthening the spastic muscles. Stop unwanted movements and associated reactions from occurring during movement and function. And we can teach methods of reducing abnormal posturing of arm and leg during the task performance. Now I'm giving you some examples of inhibitory techniques. Let us say we have a patient who has got a severe degree of spasticity in his upper extremity when he sits. What we can ask him to do is move his trunk slowly towards the affected side and then forwards and backwards as far as possible. While he is moving in this way, as a therapist, what we can do is hold his affected hand fully extended at wrist and fingers, arm in external rotation. Be sure that these movements are done by the patient and not by you. The therapist will only follow patient's movement while giving inhibition distally. This is a simple technique that can be tried. But suppose we have another patient when the arm bends while standing and walking, so-called flexor spasticity. What we can do is make the patient sit on a chair, trunk bent forwards and downwards, so that his arms are hanging down extended at elbows, and move and swing the affected arm, followed by swinging both arms. Then slowly ask him to get his trunk straightened up, keeping the head bent down, arms remain hanging, extended at elbow. Lastly, he can lift his head slowly to stand up and walk. Now, at this point, find out at which stage of walking the arm flexes again. It could be possible that when he flexes again, when he takes a step with the sound leg, which indicates that he has insufficient weight bearing and balance on the affected leg, or maybe when he steps with the affected leg, which indicates that extensor spasticity is making it difficult to lift it for a step. Then we can address the concerned area. Use of facilitation technique. Facilitation is nothing but a process of intervention where we use the improved postural tone in a goal-directed activity. You make a goal and try to use that. Give patients a sensation of normal movement on their hemiplegic side. We can give them a system of relearning normal movement of trunk, arm, and legs. Stimulate muscles directly to contract isometrically, eccentrically, or concentrically, and we can also incorporate methods into functional tasks and occupations by making them use the extremities. Now coming to the assessment part. Obviously, any assessment begins with your observation. And what we observe is when a patient comes to us is, how is the patient moving? How is that related to his normal tone? Is he having balance which is dynamic? Can he change his position? Or does the patient compensate by using the unaffected side or the affected side? And then how does he react to being handled or being moved? So these are things we need to do besides your normal musculoskeletal assessment that we generally do with a stroke patient. Then we have to find out, why is the patient demonstrating those? Is it because he's got excessive tone, or is it because he's got associated reactions, or increased or decreased levels of balance mechanisms, or increased or decreased sensory input? It could be either of these factors that is making the patient function in the manner which he or she is demonstrating. Because unless we know why, we cannot answer what. Now, once you have assessed it, then we have to think, what can we do about it? What level do I start? Should I start at the trunk to gain central postural tone, or gaining the balance mechanisms, or the most mobile part? We can use the proximal key points of the shoulder girdle or the pelvis. We have to take a decision there. Treatment, what can I alter now? Can I alter the tone? Can I alter the balance problems? Can I get the midline orientation proper? You start making short-term goals and then long-term goals. Thank you very much for your patient hearing.